away.
Hi, everyone. Welcome to our cultural competency training for fellows. I appreciate you all being here. I know nobody else had anything else going on today, so we appreciate your time. So I'm just going to go through some quick housekeeping rules with everyone. Make sure you keep your lines muted when you're not speaking. And feel free to use the chat box if you have any questions, or you can feel free to interject as we move along. We're going to try and stay off camera unless you're presenting, just to preserve some of our bandwidth. We've been having a lot of bandwidth issues with everybody, all the extra people being on camera, working from home lately. So we're going to stay off camera. Presenters, I will advance your slides for you, so you can just let me know when you're ready to move on, and I will take care of that for you. So today we have with us Kathy Costello, who is our fearless leader and AVP of Healthcare Access at the National MS Society. She'll be followed by Liliana Mezcua, neurologist at USC, followed by Dr. Mitzi Williams in private practice, and then we will close it out with Dr. Horacio Chiong Rivera, also at USC. And with that, I will send it over to Kathy to kick us off.
Great, thanks very much, Sarah, and thanks everybody for joining us this evening. Thanks to our speakers as well, who have worked very hard to put this together. And I know that we're all dealing with lots of crises and lack of information, and which direction are we to take in this COVID-19 crisis. So I appreciate your participation in this also important topic. And for those of you who listen later, this information is really for everyone. So please share it with your colleagues, even with your mentors. I know that each institution is by and large having initiatives around cultural competency. But as you'll see in the short slides that I will present, that we are still having issues with disparities in healthcare. We're still having issues with biases, which will likely continue. So the more education, the more awareness that we develop, the better off it will be for us, but also for the people who we serve. And so I'd like to go to the next slide, which is just a little bit of background. And this is really the National MS Society's statement about diversity. And we are not a protected entity, but we are your partner in healthcare. And we support people with MS. And so attention to diversity, attention to our own biases is very important to us. And we do believe that we are a movement that is by and also for all people affected by MS. And we need to have our voices reflect the diversity that's there. We value and we welcome all the perspectives, and particularly champion the diversity of perspectives that enrich the information that we have. And we also want to believe that we are an organization where anyone living and affected by MS can see themselves, and so that they know that we are attending to that individual, their problems, their needs, their issues. We believe that that is important to our overall mission and our vision. We seek a world that is free of MS, and we look to provide solutions to the challenges that people experience as they live with this disease. So we hope that our drive for diversity is easily seen by all, and we certainly hope that if people are not able to see themselves in our organization, that they reach out and let us know. It's very important for us that we are reflective of all perspectives in MS. Next slide. And so now to the issue at hand, cultural competence. So what is that? So it has a broad definition, of course, and this is from Georgetown University, their Policy Institute, and I think this was part of your pre-reading, not particularly this section, but the cultural competency and implicit bias in healthcare. So it's the ability of providers and, of course, organizations to understand a lot of factors and integrate that into healthcare delivery, into the structure of the system, and into that individual care delivery. So what are those factors? And there's many. Some of them would be race, ethnicity, nationality, language, gender, socioeconomic status, physical and mental abilities, sexual orientation, occupation, just to name a few. And all of these need to be taken into consideration, and we need to think about our own thoughts and our own values around these as we are delivering care. So organizations tend to develop processes and structures around diversity and around competency, and they're often around educational initiatives for the staff, for the providers and other staff. And this is often in yearly training that people have to take, but often it comes without a lot of individualized attention to what those individual factors are, and not just for providers, but there are factors in the people that we serve that also are part of this overall cultural competency. Next slide. So the goal clearly is to provide the highest quality care to every individual, regardless of the factors that I mentioned, and being able to put them aside to be able to see someone clearly and to see someone without bias. Can you click again? So this is easy, right? Every one of us believes that we practice in the most culturally competent way, and that we're able to put our biases aside and provide that highest level of care. Well, let's look at some statistics and see how that is going for us. Next slide. So as it turns out, different racial groups and ethnic minorities will comprise about half of the population by 2050. There's also an increase in the in people over the age of 65, 20% of the population by 2020. There are 18 million non-English speaking people, not just obviously MS, but just anyone, and less than 50% of those who needed an interpreter for their healthcare visits were able to have one. We also know that there's an enormous number of people, 54 million, who are considered severely obese. And we also know that there are 40 million people with low literacy. Why do I pull these out? Because these are some of the areas where we actually have some implicit bias. And unfortunately, these can negatively impact the care that we provide. Next slide. And as it turns out, there's a lot of groups that are not satisfied with the healthcare that they receive. Interestingly enough, the Caucasian population was quite satisfied by and large, but you can see when we look at some minority populations, they were not so satisfied with the healthcare that they were receiving. And that's unfortunate. That's not that long. That was 2002. I have other data that was actually 2019 that's still identifying these issues and lack of satisfaction with the care received. Next slide. So implicit bias, which is certainly one of the reasons why there is a lack of satisfaction and why people are identifying issues within the healthcare system and with specific healthcare providers. So implicit bias is a tough nut to crack, as it turns out, because it's going to stem from subconscious associations that we have made, gathered over our entire lifetime. And despite the fact that on a conscious level, we believe that we are practicing without bias, unfortunately, we do have biases. They're built in, and they're hard sometimes for us to recognize. These tend to come out when we're tired and stressed, and they're actually worsened with rapid decision making because we don't have the time to sit and think about looking at a situation completely clearly. When we make those rapid decisions, those implicit biases can impact the decisions that we make, and they can, in fact, invade the factors that we're using to make decisions. So this actually reduces quality of care, It changes our history-taking questions, and it can lead to misdiagnosis, and it can lead to other errors in our care delivery. It's frightening, actually, but it is that important. And it was identified a number of years ago, and in various papers that have been presented, even over the last several years, and including last year, we are still identifying this as an area of problem. Next slide. So you were all asked to take a look at the project implicit association tests and hopefully take one or more of these tests, which I found to be really remarkably revealing to me personally. I'm certainly not going to ask anyone to reveal what they learned, but I do hope that you have taken one or more, and if not, perhaps you will. This is on the harvard.edu website, or you can just Google Project Implicit to get there. And these association tests have been determined to be have quite a lot of validity, and they can be quite surprising to us, sometimes in a good way and sometimes in a surprisingly negative way. But I think what they do and where they're important is they identify things within us that we may not have known, and that provides us with awareness. And awareness is a great place to begin to start to identify our own biases, particularly those that are implicit, so that they don't invade our decision making. They don't invade that history taking. They don't lead to misdiagnosis and other medical errors. Next slide. So how can we improve? We all go through these trainings, and in fact, some people may have looked at the title of this and thought, come on, I just did that for my institution. What is this going to teach me? Well, repetition is actually pretty important, and continuing to identify and think about the factors that make us less culturally competent than we think we are. One is awareness. The other is education, and education about what are the differences. And in MS, what are the differences in different ethnicities? Because there are some significant differences that will impact the care that is delivered. How do we take a history and make sure that we are taking it without bias? Can we show and learn more empathy for what people are going through and some of the things that we may have that implicit bias about? It's remarkable how many of us and how many people have bias against someone who is obese. I read a paper about this where an obese person with pain in their lower extremities was written off for a year by a multitude of providers and said that your problems stem from the fact that you are obese, and that's affecting your lower extremity pain. As it turned out, there was a completely different diagnosis. It had nothing to do with the person's weight, yet this person suffered for a year because it was assumed that the problem was due to their obesity. Maybe it would be, but it's important for us to look at that whole person and try very hard to do that in the absence of those built-in biases. Can we show greater respect? And can we show more humility? These are some of the factors that I looked at and that I read that can help us as we strive to develop our best practices, and that we hope to deliver the highest level of care possible. And so I believe that is my last slide, and I'm going to turn things over to Dr. Amesco.
Hi, everyone. Can everybody hear me?
We can.
Perfect. All right. Well, that was an excellent introduction. And so what I'm going to do is try to give you some of the latest data in respect to multiple sclerosis and how it affects the Hispanic population. And so I will start, and you can advance my slides. And here are my disclosures. So my outline will focus on trying to show you some of the issues that underscore the importance of studying minorities affected with MS. We will go over about basically just looking at the prevalence of MS and recognizing that it varies by geography and race and ethnicity. We understand MS is a genetically complex autoimmune disease, and with that, we note that some of the highest prevalence is noted in the North American, European countries, and some of the lowest is found in Latin America, African, and Asian countries. But nevertheless, we are noting some changes, particularly in the United States. And we can move forward in the next one. Sorry, I'm trying to see. Okay, great. It delays for me for some reason. So some of the changing demographics that we have seen in the United States is that, and these particularly come from very large healthcare system databases. The Kaiser Permanente and the US military veteran studies were able to show that we are seeing changes in the average annual incidence rate, at least from the time periods that they were studied. Particularly, we were surprised to find that the African American is twice more likely now to get MS. But what we're also seeing from the Hispanic population is that the Hispanics, nevertheless, for the Kaiser Permanente showing that they're perhaps at lower risk, the US military veteran is showing higher trends over time. And so these changes are definitely something for us to consider and a reason that underscores the need to study MS in Hispanics. Next slide. Next slide. The second reason to study this population is that there is very little known about this population. This is a paper that I invite you guys to read. This is from the late Omar Khan, who basically what we did was we looked at all the literature published in multiple sclerosis that would consider African Americans or Latinos to be included. And we found that less than 1% of the literature is representative of this population. So again, another reason that underscores the need for us to better understand this population and what their needs are. The next slide. The third reason is why we need to look at this population is particularly the alarming results that we obtained from this recent study. What we did was we investigated the age-specific MS mortality across individuals of different backgrounds of race and ethnicity using the CDC. So this is the Center for Disease and Prevention database, which is an epidemiological research system that allows us to look at mortality by looking at death certificates related to multiple sclerosis. It is considered to be representative of the population of the US, at least of the 20%. And we were able to show drastically that there is differences in the burden of disease. Particularly, what it's showing is that the age-specific MS mortality pattern seems to be particularly striking among the African Americans. So here you can see that here this shows the patterns, and I wish I had the pointer, but basically the non-Hispanic Black, which is determined by the yellow coloring, shows that the non-Hispanic Blacks are dying at the highest rate under age 55. Of interest too is noting that the Hispanic, which is this little purple line, overall has a low mortality overall. We don't know the causes behind these observations, but we could certainly suspect from the non-Hispanic Black that perhaps the disease severity is different. Certainly from the Hispanic, we don't know, but from other studies and other chronic conditions, we do know that there is a healthy immigrant effect, which could alert us that there are protective mechanisms that they have, allowing them to have a low mortality. So again, this is a study that is underscoring that the weight of the burden of MS is just different across these populations. Next slide. So these variations just in the prevalence, mortality, and burden tells us that there are likely health disparities. And these health disparities, of course, we don't know if they are related to health inequities. We suspect that there are, and some health inequities are related to differences in the access to or availability of facilities and services. So certainly we want to better understand what are those factors, because our whole goal is to strive for equity. And of course, health disparities are generally understood to refer to these systematic differences, but we also have to remember that these populations are at a higher risk of social disadvantages. And so our whole goal is to try to determine what those are and what things are modifiable. Many times we have this, erroneous assumption that that a lot of it is due to biological factors, but in reality, it's underscoring that it has to do with environmental factors, socioeconomic status, lifestyle factors, or even just, the biases of healthcare providers, which we are trying to address here, for us to better understand the needs of the population and how we can best treat them. Next slide. So what is the definition of Hispanic and the relevance to MS? Well, we do know that there's a large intersection between race, ethnicity, and ancestry, and they're used interchangeably, but we need to recognize that they're actually not the same. So when, in many cases, race is, just thrown out there, and in many cases is trying to infer biological differences, but this biological differences is almost mythological, because it comes and it has actually a historical and political connotations sometimes that can lead to racism. But nevertheless, it's trying to infer biological differences to try to better understand phenotype and genotype. On the other hand, ethnicity is trying to inform social differences that are related to culture, language, and religion. And this actually requires that the individual actually identify itself with a background. Now, everybody's familiar with ancestry, as particularly this, 23andMe and all of this, trying to better understand the genetic variation. So genetic variation, I think, is trying to help us try to unravel the differences between what could be genetic or biological from genetic predispositions. And so here I put two examples of two individuals by, looking at them. One may classify their race as white, and the other one may classify themselves as Black. They're both Hispanics, and when you look at their ancestral components, they have three-way admixture that is probably varying in proportions, but with different origins. And so what ancestry, at least the genetic ancestral components, are trying to help avoid misclassification. And again, is trying for us to use ancestry-based health disparity studies to try to help us unravel some of the differences. Next slide. So in this, right here is what the average genetic admixture looks like for a Hispanic Latino in the United States. They have varying proportions of European ancestry, ranging from 40 to 60% in the most typical Hispanic, with 30 to 40% of Native ancestry and 5 to 15% of African ancestry. So these genetic variations could be important, particularly because we are dealing with a disease that has a genetic component itself. Next slide. So what are some of the aspects to consider when you're looking at the disease of multiple sclerosis in Hispanic and Latinos? We'll go over some of the risk and course and presentation. So definitely of importance is to look at, overall, what mimickers to consider when you have an individual that is just coming from Latin America. Well, There is applications of criteria to go over, but certainly copper deficiencies, other vitamin deficiencies such as B12 are important to consider, and infectious diseases such as neurocysticercosis, which is quite prevalent in Latin America. In fact, actually, we've had several cases here in Southern California, Los Angeles, where individuals actually had neurocysticercosis and not MS. But we've also had the opposite, where individuals in Latin America that later on immigrated to the US were initially treated for neurocysticercosis that eventually actually was MS. So it's telling you that this is a mimicker that can certainly occur in this population. Next slide. Another mimicker to consider is, of course, the neuromyelitis optica spectrum disorders. We know that they are likely more prevalent in non-European populations, so it's important to be cognizant of this, of NMOSD, particularly if someone is presenting with a lot of optic neuritis and spinal cord syndromes, and brain is, not particularly looking like MS. And this is a study just to remind us that there are areas in Latin America with very lower frequency of NMOSD, and this happens to be where there's higher European influx, which is an interesting observation, as opposed to areas of high NMOSD frequency. And here, if I had a pointer, you could look at sort of the frequency among Caracas, which is in Venezuela, of 43% reported, and Martinique, which is high African ancestry, noting at 27%, which comprise a high percentage of people from African descent. So this is important just to note that certainly it's a mimicker to consider in not just the Hispanic, but Asian population as well. Yep. Next slide. So what have we learned about Hispanic and MS? Well, there's a lot of cross-sectional studies that support unique clinical characteristics to Hispanics. While we're still in the infancy, we are noting that there are, certain aspects of MS that is particularly defining this population. So age of onset appears to be younger compared to whites. We're talking about 3 to 5 years younger. This is not only a year of age of first symptom, but also age of diagnosis. So this could actually tell us that it's even younger than expected. We have noted that is even much more significant when the individual is US born compared to those that are migrants or, foreign born. So, but what is interesting about the foreign born is that the late migrants don't develop MS until about 15 years. So we've looked at basically about 75% that were, of the Hispanics that were foreign born were developing MS on average 14 to 15 years later, which is consistent with past data in MS that migration has an impact of when one develops MS. But what is also important is to recognize that that foreign born or place of birth also impacts the risk of ambulatory disability. Of course, this, what we've had found was that the late migrant was greater risk of ambulatory disability, which could tell us that there's issues with access, utilization, other social factors that we don't know of. Apart from the age of onset, we are particularly noting that the Hispanics are twice or more likely to present with optic neuritis, but also transverse myelitis, so spinal cord involvement is quite common. We also note that they have lower vitamin D levels compared to whites, and I'll go over that a little bit more. And then, of course, that this genetic ancestral variation may have a relationship with why this population presents the way it does. Of importance, of course, is that there's a study from New York noting that the age and gender adjusted disability scales was significantly higher in the Hispanic compared to Caucasians. And so this is telling us that they could be also at higher risk of faster disease progression. This, of course, all of these studies need to be done in larger and longitudinal to better understand, but certainly all of these studies there's something unique to this population. Next one. Oh, no, I can't see it. Sorry. There we go. And so in terms of the genetics, what we have done is that we've aligned with different institutions to better understand some of the genetic ancestral variation in relationship to some of the clinical characteristics. And this is a study that it's basically related to what we call the Alliance for Research in Hispanic MS. So it's the first consortium that we spearheaded to try to combine as many Hispanic cases across 4 different academic institutions. It was just not any type of case, but basically all of these institutions have registries where they have been collecting Hispanic cases in the same way. We have aligned our database capabilities, but we have also, basically collected blood samples to better understand, how this relates to in this case, because of what we were saying, that perhaps optic neuritis is a much more frequent presentation and age of onset is much younger. We wanted to do a within comparison within Hispanics to take a look at that genetic variation, given the fact that 3-way admixture. And so in here, in this slide, you can see the variation of ancestral background for 4 different institutions. So you have as University of Miami, USC, University of Southern California, you have Puerto Rico on the right-hand side upper, and UCSF in the bottom. And you can see here, let's say University of Miami has overall individuals with higher proportions of European, which is designated by the red. And if you could basically draw a line down each bar, so each individual is represented by 3 colors. And so you can see here that overall the average of the University of Miami constitutes on the European component a 40 to 60%, versus in the USC, which is Southern California, has a larger proportion of green, which corresponds to Native American. And this is salient to, again, to the population of that region. So we are not seeing differences to what we would expect for those regions. Puerto Rico has the highest influx of African, and we can see this by the varying proportions in blue. And so, so you can go on to the next slide. And so we calculated the percent of patients presenting with optic neuritis, and you can see that both Puerto Rico and USC had the highest proportions of presenting with optic neuritis, but you can see between institutions is ranging between, almost 20% all the way to, above 35%. And we estimated their ancestral genetic proportions using that mixture, and then we looked at the likelihood of optic neuritis presentation by quartiles of this Native American genetic ancestry. And what you can see is that those in the highest quartiles with Native American ancestry are twice more likely to present with optic neuritis. This is independent of African ancestry and age of first symptom. Seems like females were more likely, but it was not statistically significant. And it seems Puerto Rico or USC, because you can see the higher proportions of being presentation, contributes to that as well. So this is telling us that there is likely some genetic aspect contributing to the presentation of optic neuritis. Next slide. In terms of the modification for age of onset, we also noted that it was not only the Native American, but African ancestry independently also increases your risk. So the more African ancestry you have, the younger age of onset you have with multiple sclerosis within the Hispanic population. This is also noted for those that have Native American. So there's something about that, those SNPs that correspond to Native American and African ancestry that influences the age of onset for multiple sclerosis. Interestingly, we did look at other common genetic factors such as HLA-DRB1, 1501, at least at its marker, and other MS risks that have been used in European populations, but we did not find any significance in this large Hispanic population. It could still be a sample size in that respect for this specific HLA matter. Next slide. In our latest study, we also now included African Americans with and without MS, along with Hispanics with MS and without MS. And what we wanted to better understand was to test the relevance of the 200 plus known genes to be important in MS risk in whites. And what we found was that there was less replication overall for both populations. This is not unexpected, but what was interesting was that the replication increased as European ancestry increased. So it is telling us that Hispanics and African Americans with MS in a way are much more alike to whites with MS, but yet there is still a regions or areas that are likely not as important of the genetic risk. We also looked at the genetic burden and pathways and found that cumulative genetic risk scores were associated with MS within each study sample when obviously compared them to controls. And you can see here sort of seeing the different colors. The blues are for the African Americans. There was looking at Hispanics within the greens and comparisons with Asians and Europeans within the reds. So there's definitely a higher weighted risk score for those that have MS overall. Next slide. So what do we know about investigations into known environmental risk factors in whites and now in Hispanics? Well, we do understand that they may not be as relevant to Hispanics. And this, in terms of vitamin D and sun exposure has been recently looked at in Hispanics. So what has been really helpful is the multi-ethnic studies, particularly from Kaiser Permanente, confirming that, higher levels of vitamin D do definitely lower the risk of MS, particularly in whites. But so far in that study, it did not show to lower the risk in Hispanics or African Americans. But also what we have known is that Hispanics overall are more likely than whites to be vitamin D insufficient and deficient. We also have known that we have the vitamin D levels don't necessarily are influenced by season in this population. We've looked at higher physical disability or relapses, and those come with varying degrees of findings. Nevertheless, this has not been replicated, so I think there's more studies to be done. But what was interesting was that the Kaiser Permanente did find an association to sun exposure. So what do we do when we have this challenging type of data? Well, right now, I think the vitamin D supplementation is common practice in MS. We do recognize that different factors influence vitamin D levels, and that possibly vitamin D requirements may vary by race and ethnicity. So right now, as a practice, we do supplement our patients, and I think there's just more data to be done. Next study. Yeah, next. So what do we know? We all know that EVV is a risk factor for MS and that CMV could be protective. In this multi-ethnic study from also Kaiser Permanente, we were able to show that EVV seropositivity was independently associated with an increased odds of getting MS in all three racial ethnic groups. So it appears that EVV is important to all these three groups. Interestingly though, however, for CMV seropositivity you can only see here that it does seems to be associated with a lower risk of getting MS only for Hispanics. It doesn't seem to be important in Blacks or whites. Of course, you know, the confidence intervals are a lot larger. But what is interesting about the Hispanic is that some of this driver, the seropositivity of CMV, has to do with being born in low and middle income countries. And this has to do with exposure of CMV. So the lower middle income countries are exposed at a younger age with CMV, which again is telling us that there could be protective mechanisms that certain populations do have. Next slide. This is a new, this basically right here, it's a new paper that we just published. This is a systematic review looking at all the disease-modifying treatments and their outcomes, and actually African Americans, Asian, and Hispanics. I am just putting up some of the Hispanic studies just to highlight that we have very little knowledge about DMT efficacy or effectiveness in this population, but nevertheless, within this limited data, we can see that you know, there is some evidence suggesting that at least here for methyl fumarate and fingolimod is showing that they do well. But I need to remind you, the participation rate of this population in these studies was less than 10%. So I think there's still a lot to do to better understand if they would need to be treated differently. And so I think from here, what we can say is that, and once you look at that systematic review, is that a lot needs to be done to improve participation of these populations and to better understand if there's specific ways of treating these populations from the start. Next slide. So what cultural aspects of care in Hispanics and Latinos should we aware of? Well, Hispanic heritage is tightly linked to language, culture, and health. And in health is really important because, you know, the Hispanic heritage does influence in the way that you see disease and the healing practices that that individual may engage with. Next slide. And communication, so language in the Hispanic population is really very important. There are differences to just be aware of, particularly when it comes to the individuals that have lived here in the U.S. You know, they commonly use a mixture of Spanish and English. I'm sure you're familiar with Spanglish. And so it is important to recognize, but nevertheless, even that generation tries, they emphasize on respect or respeto. There's a formality between the older individuals and the younger individuals. And in respect to healthcare, it is uncommon for Hispanics to be aggressive or assertive. So they may look like they're just, you know, being non-compliant, and they tend to be silent, not communicating their fears or questions that they may have. So we sometimes need to prompt them a lot more. Next slide. There are also cultural themes that we can be aware of treating this population. And this is not necessarily related specifically to MS, but just in general, studying the Hispanic population in the United States, showing that there are cultural themes to be aware of that could definitely impact the way they respond to their health. So familismo is related to the importance of family at all levels. So that's why you probably see, individuals bringing family in. So the needs of family are really important to them. Sometimes it'll overtake in terms of them taking care of themselves. There's the issue of personalismo. So it's more of being personal. There's, showing mutual respect, and this can actually help building trust. jerarchismo, or it's more of like, you know, respect for hierarchy. I think I just mentioned it. So those above and so those in the bottom. Unfortunately, that's probably a result of colonization. And so unfortunately, that can have an impact. Presentismo is emphasis on the present. So this population tends to stay very focused on the present and not, you know, hold on to the past. Espiritismo is they have a strong belief of spirits and how they can affect. Later on, I'll talk a little bit about susto, but basically the soul is really important. Fatalismo means that they have an external locus of control. And so this definitely may come out as like, well, you know, God gave me MS. It's a challenge that God gave me, but this may also lead them to become passive and not be very involved in their health. So we have to be careful with how fatalismo can turn out to be in this population. Next slide. So to better understand some of the cultural themes that we have heard about Hispanics, we did do a study on about 100 Hispanics with MS to try to better understand some of the distress aspects of these cultural themes. And what we found was that there is indeed social cultural perceptions, particularly related to susto. And here you can see that, you know, 60% actually talked about some element of their body, soul leaving, you know, and causing them so much stress and then coming back and then them getting MS. And so this is how they interpret this. Others talked about tristeza, which basically almost translates to depression, but it's a little bit more intense as being the cause of their MS and the issues of fatalism, of you know, just trusting in God and not being very aggressive about their disease. Next slide. But what was interesting was that we did see that certainly those of that were foreign born increased the risk of believing a cultural perception. They were 3 times more likely to have these type of social cultural perceptions. And this was irrespective actually of sex, income, or education. In fact, actually these 100 patients, they were, you know, mostly had high school or some college education. And most of them, you know, and they still had this strong, you know, sort of cultural perceptions that were salient to them. What was also interesting and of course concerning is that not receiving DMT was more commonly reported by those who reported these perceptions. So it's certainly important to, you know, perhaps try to better understand what they perceive as them having MS, or if it comes to understanding why they're not wanting to have a disease-modifying treatment. Next slide. So what can we do to try to better have a stronger communication or language with this population? Well, I think Hispanics overall expect, and I think that goes for everyone, expects healthcare personnel to be warm and personal and express a strong need to be treated with dignity. And, you know, Kathy's talked about, you know, empathy and humility, and it's apart from, you know, it's dignity, humility, respect, and it's really important to build that rapport. And how do we build rapport? Well, I think a lot of them like to start with a little chit-chatting, and again, it's not necessarily just to Hispanics, but I know I do see it much more frequently in that population where they are there to see you. But before they go to the business, because they consider MS a business, you know, they want to chit chat. They want to know genuinely about you, they commonly ask me about my kids. They commonly, you know, they want to get that first, and then we move on. And so that provides a little bit more, you know, sort of a rapport and trust, and then, you know, this can become much more personal to them. And certainly if there's family there with them, involve the family. always you can turn to them and ask them questions. If they brought them, there's a reason. They brought them because not necessarily just a silent support. They commonly want them to be involved also in providing some, aspect of what they think the care that I'm, suggesting. And next one, oops. And I think that's maybe one behind. Yep. One behind, two behind. I think you just went over the summary. So here's the clinical practice points in summary. So Hispanics also get MS, and it seems that there's a higher risk to present at a younger age. I think that's important to recognize. And, oops, moving. And seems optic neuritis is a very common presentation, much more common than whites. There seems to be genetic predisposition as well as environmental exposures that may differ and could contribute to the variation in presentation that we are seeing. So certainly there's a lot more work to do. Hispanic as an ethnicity and heritage is a complex construct, and we need to be just cognizant that it may interfere in our MS and the way we treat and care for them. So recognizing cultural concepts that I just went over in terms of communication, beliefs, and distress, I think can also improve disparities. And so I think we're just at the beginning, but there's a lot more work to do. But with your being aware of these, I think it can help us improve overall disparities in care. And I'd like to acknowledge and thank you for your attention.
Okay, well, good. Oh, sorry, go ahead.
No, I was just going to thank Dr. Mesqua and just to turn things over to you, Dr. Williams. So thanks very much. Hey, good to see you.
Absolutely. Good evening, everyone. I'm very excited to be here and talk about this topic, which I think is extremely important. And I bid you greetings from Atlanta, Georgia. And since we are running a little short on time, we are going to just go ahead and start and get right into the presentation. All right, next slide. So I'm going to talk a little bit, these are my disclosures. Next slide. So I'm going to talk a little bit about MS in the African American population. Some of this information has been covered in some of Liliana's slides because some of the information overlaps between African American and the Hispanic Latino population. But these are the things that we're going to cover. We're going to talk a little bit about the phenotype of MS in the African American population. And then we're going to talk about some of the challenges to care for these patients, as well as I wanted to take a little time to focus a bit more on research participation, because that is really a key component to helping understand the needs of this population, as well as understand the clinical characteristics, and also is a large part or a large area where we need certainly cultural competency so that we can explain these studies and encourage people to get involved. Next slide. So when we think about the face of multiple sclerosis, there's a face that often comes to many people's minds, and that is a face of a young white woman. And if we think about the epidemiology worldwide, we certainly still see the highest prevalence in the UK and areas like Scandinavia and Europe. So worldwide, this probably still is the most common face of multiple sclerosis. But as some of the information we've discussed already shows, next slide, when we think about the United States, this is becoming a more common face of multiple sclerosis, and that is the face of an African American woman. So the Kaiser data that was presented earlier suggests that the risk for multiple sclerosis is up to 47% higher in the African American population, primarily being driven by higher rates in African American women. And I know that for myself, coming along in my studies, as a resident, as a fellow, and even early in practice, it was just kind of common knowledge that African Americans did not really get MS. And when I got into practice in Atlanta, Georgia, where obviously there are lots more African Americans in the South, probably half of our population at very, very large MS centers are African Americans. So we have a lot of work that we need to do to understand this population and to make sure that we're treating people compassionately and effectively. Next slide. This is just a slide looking at the Go Forward data, which has already been presented, again, suggesting that the incidence is highest in African Americans and women more so than men, but certainly the men also have a higher incidence than their white counterparts. Next slide. When we think about prevalence, again, data that has been partially presented already, certainly one of the issues is that we do not have a lot of data about MS in African populations, especially Black African populations. Probably every year I do a literature search to look for more information about this group, and there just is almost no data present. So there are occasional cases that are reported. There are several case studies that suggest there may be a variant between MS and NMO SD in this population, but there is virtually almost no data to help us really understand MS in the Black African population. Next slide. So when we think about the ancestry of African Americans or Black people can be kind of split up into two groups. So we have primarily here in the US, those who are descendants of people who migrated here, Africans who migrated here from the slave trade. And so there's a lot of genetic admixture in this group. Certainly there's roughly 20% European ancestry and 70 to 80% African ancestry. But one of the challenges is that there really is not a good sense of place of origin. So we know that many people likely descended from those who came from West Africa. But unlike many of our Hispanic populations where we have a country of origin, maybe Mexico, maybe Cuba, you know, for African Americans, we don't really know where our ancestors came from, you know. So certainly with the advent of genetic testing, you know, that can improve, but there's really not a sense of a population that people can be directly compared to help understand some of the admixture. The other thing is that environmental factors may play a role in increasing the risk as well as the genetic admixture, because again, we don't see a lot of cases in the Black African population, but also there may be a need for more resources and neurologists in those areas to help understand the population better. One of the other things that was alluded to as well is that African American race, I put ethnicity, but race is determined by self-identification. And so people are Black because they say they're Black, and we really don't know very much otherwise. So there are some people who may have more African genes or in their genetic makeup than they are aware of, and there's some that may have more European ancestry than they are aware of. So there's a need to help identify things on a more biological basis versus just self-identification. Another large issue, especially for those who may be also of Hispanic ethnicity, is how they identify. So often if people are given a choice and they consider themselves both Black and Hispanic, they don't have an option to check both of those boxes. So when we're talking about, you know, kind of renovating the way we do research, how can we make sure that people are fully self-identifying so that we can capture the correct data? Next slide. Clinical characteristics of MS in African Americans. So I'm going to go through this fairly quickly, but there are some things that we've determined from the literature that we have available. As we discussed, there's very little literature looking at MS in the African American population, less than 1% of the literature, but from the data that we have, there are some things that are themes that seem to be pretty prevalent. So one is that disease progression is faster in the Black population, and that's both looking at MRI measures in terms of lesion load as well as retinal atrophy and optic neuropathy is more severe in this population. When you look at MRI data, whole brain gray and white matter atrophy occurs twice as fast, some papers suggest, as in African Americans as Caucasian Americans. And also there may be faster atrophy of the thalamus, which could lead to more cognitive impairment. And there are a few studies that suggest that there may be more severe cognitive impairment in this population as well. Next slide. Other clinical characteristics: higher T2 lesion volumes, more gadolinium enhancing lesions, lower NAA values, lower brain MTR, higher CSF IgG. And so much of this points to a possibility of a more B-cell driven humoral autoimmunity, and that may be driving what we see in terms of more aggressive disease. But again, there's a lot that we don't know. We do not know the factors related to social determinants of health, how this may affect the outcomes. And because we don't have very much clinical trial data, we don't really have a great understanding of some of the underlying factors that are driving these differences. Next slide. What about challenges to caring for African Americans with MS? So I have one slide, and I'll just kind of park here for a minute because I think this is really relevant to what we're trying to address in terms of cultural competency. So there are many factors that play into some of the outcomes, and we just don't know kind of the balance between these and biological factors, but they're very important. So one, we know that African Americans are underrepresented in clinical trials, and so we're going to address that, or I'll address that in a few slides. But I think that the important piece to recognizing the reason that's important is because we're missing likely some of those unique cultural and environmental changes. Some of the factors or challenges to care for African Americans is, number one, we don't have a lot of data. So when we see studies that suggest poor outcome, when we see our clinical trials that suggest maybe equal outcomes in terms of efficacy of therapies, when we have very, very small numbers of people, it's difficult to generalize those results. So we don't really have an understanding of the biology like we should to figure out why we're seeing some of these worse outcomes. Another huge piece that's extremely important to caring for African Americans with MS and African Americans in general is the distrust of the medical and research community. So there's a very long, unfortunate history of racism and discrimination and bias, especially against the African American community, that has been present for many years and in many ways is still present today. And so it's generally built a mistrust for many people of research and of the medical community. You know, there are studies that have looked at things such as the Tuskegee experiment, which was involved with not treating people for syphilis and basically watching the outcomes of syphilis without treatment. There also is a lot of talk about other injustices, such as the Henrietta Lack story of the woman who basically the HeLa cells that were used to really revolutionize science. Her cells were used and sold, and her family knew nothing about it, and many people benefited, and they didn't know anything about it. So there are these stories, but even though these stories in particular may not be the reason that some people are not trustful of the medical community, there are many other stories that are told in families and other places that has kind of built this mistrust. So one of the huge, most important factors is establishing a trusting relationship with our patients and explaining things, especially when we talk about asking people to be involved in research. We want to make sure that we're explaining the studies and the benefit to the communities. And we're finding that people are more receptive to being involved, but we have to make sure that we're asking the right questions. Also, socioeconomic status and access to care is huge. A huge challenge in terms of caring for African Americans. People may not have access to MS centers. They may not have access to MS specialists. They may not have insurance. They may not have access to medication. So making sure that we're providing the appropriate resources is very important. And then the other factor that is extremely important is religious beliefs. The church plays a very large part in African American heritage and in the African American community. And so there are many treatment decisions that may be made based on religious beliefs. And in some ways that can be very good. In some ways religion can be protective from symptoms like depression and anxiety. But in other cases it may hinder treatment. And so we have to find a way to acknowledge the importance of those factors, but also to educate people about the importance of treatment as well. Next slide. This is a study just looking at access to care in the United States, and this is not specific to MS, but just specific to neurological disorders. And it suggested that African Americans were 30% less likely to see a neurologist. This is important because if African Americans or a patient see a neurologist, they often have a treatment for their MS, and they often have a plan for symptomatic treatment, which can significantly improve their quality of life. And then there were other measures. African Americans were more likely to be seen in the emergency room and have inpatient stays with higher hospital expenses, which again puts more stress on the finances, which could affect their MS care in the long run. Next slide. So what about clinical trials? So minorities make up less than 10% of clinical trial participants. And this is not something that's unique to MS. It's really pervasive across all areas of medicine, including conditions like hypertension and diabetes, which are very common in the African American community. Next slide. So let's just look at the numbers. And so I just wanted to make it very simple so we could just see some of the numbers from our major clinical trials for multiple sclerosis. So we know that most of our trials are primarily conducted in Eastern Europe, and so we don't have as many U.S. sites for most of the MS trials as we have as are seen in Europe. But if we just look at the sheer numbers, the highest number of African Americans in clinical trial programs is for fingolimod, which was about 62 people. 62 is a very small number compared to usually several thousand people that are in a clinical trial program. And with some of the earlier trials, for instance, with natalizumab, some of those people were on placebo because some of these trials were placebo-controlled trials if they were done early enough. So very, very small numbers of people in these trials, and it emphasizes the need to improve recruitment, but also the difficulty with looking at these sub-analyses and making any types of conclusions because it's just very difficult to make any conclusion with such small numbers of people. Next slide. If we look at the specific data, I'm just going to go through a couple of these very quickly. This is the sub-analysis of an interferon trial that Bruce Cree published back in 2005. And again, 36 African Americans versus 616 Caucasians. And what we see on the last two lines is that the African Americans seem to have a higher number of relapses, and there were fewer of them that were relapse-free at 48 weeks. Now, there are some who took this data and suggested that African Americans do not respond to interferon as well. If you look at it at face value, that could be the conclusion. But again, it's very difficult to make a broad generalization with just 36 people. Also, with some of these trials that were done very early on, people may have had more severe disease. There's a lot of factors that play into some of these results. Next slide. If we look at the natalizumab program, there are about 49 patients between both of the trials, and again, 28 of those were on placebo. So out of the 49, only 21 were actually on treatment. And although the treatment seemed to perform similarly in the African American versus the non-African descent patients, it's very difficult to make a generalization with 21 people. Next slide. And then finally, with looking at the alemtuzumab data, again, very similar, results in terms of efficacy, but very small numbers of people. Next slide. So the big question, what is the role of biology versus social determinants of health, and how does this affect the course of disease or the severity of disease in African Americans? The honest answer is we don't know. But there are many that are trying to look into this and better understand it so that we can, better treat our patients. MS is very different in each person. So if you've seen one person with MS, you've seen one person with MS. So of course, every African American does not necessarily do poorly. Every African American does not reach an EDSS of 6, 10 years earlier than their Caucasian counterparts. But certainly there are enough that do that we need to better understand some of these differences. Next slide. So why is increasing diversity in clinical trials important? This is a great study that was published in 2012, not specifically about MS, but again, emphasizing that minorities are underrepresented in trials. We're missing some of those factors that may help us understand disease, and also we may have difficulty generalizing findings if everybody is not a part of the studies and everybody's not a part of the conversation. Next slide. This was also a really great article. It's published in a cardiology journal, but it talked a little bit about some of the barriers to participation in clinical research and also the importance of increasing diversity in trials. And so some of the barriers that we can see on the left-hand side are mistrust, lack of comfort with the process, lack of information, time and resource constraints, and lack of awareness. And so these are things to keep in mind as many of you may go into academics You know, when you're doing research trials, you know, number one, underscoring the importance of having a diverse population of patients involved, but number two, understanding some of these barriers. And so some of the solutions that they suggested are here in the middle column, and I'm not going to read them, but again, making sure that you reassure patients that their safety is a number one priority. Sometimes we educate about the clinical trial process in general and make sure that they have a clear understanding and are able to ask questions. As I will talk about a little bit later through some of the work with some of our organizations, we found that, again, many people are receptive, minority patients are receptive to being involved, but many of them have not been asked by their healthcare providers, or they don't know where to find information about participating in clinical research. Next slide. Potential strategies to increase diversity in clinical trials. This is the draft guidance from the FDA. Talks about broadening the eligibility criteria. Oftentimes in our research, there may be criteria that obviously would make us have a much cleaner result, but may unnecessarily exclude populations. For instance, African Americans may tend to have more comorbidities like hypertension and diabetes. And so if the trials are very, very strict with their criteria, it may automatically exclude whole populations of people. Also, developing recruitment strategies that increase diversity. There are efforts to you know, not necessarily, I wouldn't say target, but to try to recruit study sites or involve study sites where there may be higher populations of minority patients, but they may not be some of the traditional places that we go to for research participation. So, you know, getting other investigators involved who may not be in large academic institutions may help increase diversity. Also making participation less burdensome and developing inclusive enrollment and retention processes. Next slide. The MS Minority Research Engagement Partnership Network is a multi-stakeholder group that Liliana, Dr. Amescu, and I are both involved in. That is a really great group of advocacy representative industry partners, physicians, and people living with MS. And so we developed several toolkits that are available online for free to educate patients about clinical research in a culturally sensitive way, and also to educate providers and researchers about ways to engage people in the research process. And then we also had several live programs where we were able to do some what we call myth busting and talk about some of the common misconceptions about research, such as fear of being used as a guinea pig, and also fear that they won't be able to get out of the trials once they start. And so just addressing some of those issues, and some of that content is also available as well. Next slide. The National African American MS Registry. Some of my colleagues and I have been diligently working on this for the past year or so, and hopefully we will have information about enrollment in the next couple of months. But there are efforts for people to create registries and data sets to help understand this population and help move the science forward. Next slide. So in summary, a couple of things to consider when we're talking about being culturally competent and treating African American patients with MS. Number one, we want to consider the distinct phenotypes. Again, there is evidence that suggests that disease can be more aggressive. There can be more walking disability, more MRI lesion load, and more cognitive dysfunction. So we want to be aware of that, recognizing that every patient is not automatically aggressive, but that there is a potential that for this group, they're at high risk to have more aggressive disease. Also, we want to closely monitor people with aggressive disease, not only to adjust their treatment as needed, but we also want to provide accurate information about clinical trial enrollment for appropriate patients, and recognize that many people do want to be involved in clinical trials, but there may need to be additional education, and certainly culturally sensitive education about these as well. Also, we want to direct patients to culturally appropriate educational resources for themselves, but also for their families. And what's not listed here is that families do also play a large part in decision making. So making sure that when we are starting or changing treatments, that we also bring in or make those key family members that help with decision making a part of this process, because certainly things will often go a lot more smoothly if they are part of the educational process as well. And then finally, monitoring cognitive function as a measure of disease progression, because certainly that can be more severe and cognitive dysfunction can occur more rapidly in African Americans. Next slide. Follow me on social media for those that don't. I do a lot of education about MS for patients and for healthcare providers. And last slide is a question slide, although we're not taking questions. Okay, and I always end my talks with this. All I need is peace, love, and a freaking cure for multiple sclerosis. Thank you very much for your time, and I will pass it back over to Doris.
All right, thanks very much, Dr. Williams. And again, our thanks to Dr. Amesqua. And because we are running a little short on time, we're going to move right along to Dr. Chong Rivero. Please join us and provide your case study, which is very interesting. So thank you very much.
Great, thank you so much. I will start right now. You can go to the next slide. And sorry if my voice goes in and out. I'm just now getting over a bad viral illness. Objectives, to summarize a clinical vignette, and this will hopefully provide us with some questions, and looking at skills for understanding cultural relevance to the diagnosis of MS and to its treatment. We will also ideally like to go over the cultural challenges involved in establishing a therapeutic relationship with our patients, and then ultimately applying these skills in a cultural competent way. Next slide. I just wanted to give you a very quick glimpse of his imaging that was taken in June of 2015 when he first established care at the LA County Hospital. And I'll go over more of the details in the following slides. Next slide. The history. So in 2001, roughly age 18, he had recurrent vertigo, which he thought was positional, but then he gave me a different description, which made me think perhaps more central in origin. Nevertheless, he had no medical care at the time. This resolved, so it did not turn out to be a chronic symptom. In 2006, he went to Kaiser. He had insurance then, and this was for diplopia. He was then diagnosed with MS based on MRIs and CSF findings, and he was treated with Solu-Medrol for 5 days. In 2006, for about a year to 2007, he was on Avonex. He did not like it due to the flu-like symptoms. He then switched in 2008 to the tetramer acetate, to Copaxone. And then in 2013, he went off DMT, and this was due to losing his Kaiser insurance. He was no longer able to work at that point, and I'll tell you more in the following slides. He also added that at that time, he did not think that Copaxone had been working sufficiently for him. He had been developing worsening balance, so he was off DMT for sure from that time, 2013, 2015. And then in 2014, while he was off, he remembers having worsening vertigo. The vertigo that he had had back in 2001 returned, and it was very, very familiar, very similar. And then he had some imbalance issues that were acute, but again, he did not seek medical care at the time. Next slide. Then finally, in August 2015, that's when he first presented to the LA County Hospital. He established care there, and that was to worsening symptoms, specifically the balance issues. He told the providers that he had been off DMT since 2013. The last time he had seen a neurologist was actually in 2011. He was still with Kaiser at the time, but there was a time in which he had not seen anybody for his MS. And so basically his exam, as documented in our notes, in August of 2015, was quite significant. Bilateral ionos, dysmetria, hyperreflexia throughout, but especially at the patella, sustained clonus. He had Romberg that was present, and impaired tandem, so already quite severe. In late August, he was initiated again on Copaxone while they sent off the labs for all of the other higher efficacy DMTs. Next slide. This slide, I just wanted to give you a quick glimpse of what his chronic symptoms had been by the time he presented to LA County. So since 2002, the intermittent vertigo, which I said had not been chronically present for many years, but had returned in 2014. In 2013 was when he had to stop working at a factory, and that was due to basically losing his balance and falling, having increased fatigue. And then obviously once he lost his job, he didn't have insurance after that. He said that he had not been falling in 2015. That was when he established care at LA County. And he was also denying urinary symptoms. Next slide. Then in October 2015, so this is about a month into having restarted Copaxone, he presented basically with a partial transverse myelitis, lower extremity numbness, sensory level to T4, no urinary symptoms that were acute in any way. The brain MRI, and unfortunately I have to tell you what the medical record shows because the actual imaging, unfortunately, I have no access to it. It's located at another county facility. It's a long story, but essentially what was noted was that he had 3 new enhancing lesions in the cervical cord, and also 1 in the brain, in the posterior right frontal lobe as well. It was noted to have moderate cerebral and cerebellar volume loss as well. He did receive 5 days of Solu-Medrol with improvement on follow-up. And at the time, oh sorry, in the previous slide, but at the time, the importance of switching to a higher efficacy DMT was discussed multiple times. So he actually followed up at least twice within a month to the LA County system clinics, and Tysabri was discussed, Jelenia as well, but he had very high concern for switching at the time, and then it's mentioned that he specifically had read about some of the side effects and did not think that it was worth it for him to switch at that point. Next slide. And so 2016 goes by, and we're now into 2017, and then all of a sudden, we have surveillance imaging that was done for one of the scheduled clinic visits, and 6 new enhancing lesions are seen, which if you advance to the next slide, this one we actually do have in our database. Basically on the left you see the flare to give you an idea of the substantial cortical atrophy that we already see in this young man in his 30s. And on the right we have the T1 post axial cuts with very tiny, they're not big, they're not confluent, but they're there. We counted a total of 6 punctate lesions in bilateral cerebral hemispheres. Next slide. Further DMT discussions, as you can imagine, over several clinic visits in 2017. Some of them were on a monthly basis, so providers at that point in our county system were very actively trying to switch him at each visit. So again, Tysabri, Jelenia, Rituxan were discussed with him, and especially because of his presentation. This is now an aggressive course, very high risk of progression. He's Hispanic male, young, in his 30s, already a substantial heavy lesion burden, and that included the spinal cord as well. So there was high concern, obviously, for progression in that case. He declined switching. He said he wanted to continue with Copaxone due to fear of potential side effects, when all the other higher efficacy DMTs had been discussed with him. He was found to be JC virus positive at that point, so Tysabri was actually not discussed further. And then the exams, I wanted to give you an idea of how he was doing clinically in 2017. He had really progression of his ataxia with worsening balance. And then the notes started to document more of the motor weakness bilaterally in the lower extremities, which had not really been present 2 years prior when he first established care. So this is also a progression. He had neurogenic bladder by this point, which had not been there on the year in which he established care at LA County. And the memory deficits were documented for the first time. Next slide. So switched to dimethyl fumarate in September 2017. So after quantiferin gold tested positive, he underwent TB latent. This was for latent TB. He underwent treatment, finished it successfully, and then he decided, he accepted finally to go ahead and switch from Copaxone to dimethyl fumarate. He was monitored in the clinic visits, noted to be compliant, no new signs for relapse into 2018, as you can see on the summary there. Repeat surveillance MRIs of both the brain and the cord were shown to be stable. And then there was a comment in one of the notes also, which I think it's interesting. He had stopped his vitamin D because he thought it increased his metabolism and made him have soft stools. We can discuss this further, but obviously this is part of one of the illness beliefs that he had at that point regarding that. Next slide. So in 2019, he continues to be on dimethyl fumarate. Clinically, he is having more falls, more imbalance. He started to use a cane. So he used a cane briefly, but then refused it. He had a walker, which he also refused to use. He said he can do without it. This is despite the imbalance in the falls. And he also did not want to go to PT at one of our facilities, which is Rancho Los Amigos. By July of 2019, and this is actually the first clinic visit in which I saw him, the exam was quite remarkable. Severe ataxia, hyperreflexia, Babinski's bilaterally. It took him the 10 seconds to walk the 25-foot walk, and then he had marked scissoring on his gait as well. Very striking. And he, at that point, I had the walker for him to use to test him with it, and he refused to use it, but he did the 25-foot walk basically hanging onto the walls as he did it. In July of last year, the MRI brain and the C-spine were stable. The T-spine was actually done about a month later. That was also stable. More DMT discussion was performed by me. So at that point, I said siponimod had been just approved, and it was of strong consideration. So I gave him the basic information, and I did so in Spanish and in English. And I'll explain a little bit more about this. This has to do with the fact that his mother, who's only Spanish speaking, was present. So I wanted the family to know. And he's bilingual in both English and Spanish. So I did my portion with him in English. But he declined. By the end of the visit, he said that he did not want to pursue switching at that point due to his concern for side effects. He didn't have all of the information on Mayzent. I didn't have the brochure for him in clinic yet. So that was a limited portion of information, but I did verbally tell him about what it entailed. Next slide. So this is a slide which hopes to capture some of the major issues with social determinants of health. In this case, one very big category is level of education and literacy in his case. So what happened in October of 2019, and this was a clinic visit that unfortunately I did not personally get to see him. Another provider did. In the county system, many times it's not the same provider who can see the patient for every single visit. We do our best for it to be for that to be the case so that we can have the most continuity of care, but sometimes this is not possible. So another provider had talked to him in the October visit of last year about starting Impera, and due to the worsening balance. And so he thought Impera was actually a DMT itself, and thought that he had to discontinue the Tecfidera in order to start the Impera, and that's actually what he did. So he discontinued Tecfidera, he started Impera, and basically then I saw him in January of this year. In January of this year, I had another conversation with him about switching to Rituxan as a higher efficacy DMT. And he specifically mentioned his concern for side effects. When I asked him specifically about what would those be that he knew to the best of his knowledge, he wasn't able to tell me. I then told him the basics of what we know Rituxan can do with regards to some of the common infections, and I mentioned it to him. I told him that he was what I would consider in the lower risk of developing things such as UTIs, etc., and that we would monitor very closely for that regardless. But in the end, he did not accept to switch over to Rituxan at the end of that visit. The social support category, so his mother was present again. His mother has been present at the clinic visits where I have been the provider. And so he said that things had been going very well with Impera, and the mother disagreed. So I had a chance to talk with her in Spanish, and she basically said, no, he continues to have a lot of falls, especially later in the day as he gets more tired, and so multiple falls every week. This is information that's important to gather from family members, and as Dr. Amesqua had mentioned earlier, there's a reason why family is present. It's not just silent observers. These are very hands-on caregivers who are there for, out of the best intention for the patient. And so, this is very critical information, obviously, in showing that his disease had not stabilized in any way, shape, or form. Healthy behavior. So I know this is a bit odd of a title, but PT again has been discussed at every visit. He refuses PT. He first says, I don't want to. And then I prompt as much as I can, what are the reasons? Has he had a bad experience with some members of the staff? Has he done some maneuvers that have caused pain in a way that he had not anticipated? What could the reasons be? He basically said, no, none of that. He loves the people in PT. He loves the environment, but he thought he could do it himself at home, being self-sufficient, and do the exercises at his home gym, and did not have any interest in going to PT, even with the transportation being something that could be provided for him through the access system from LA County, but he declined to do that. Language, as I mentioned, it was important because in the clinic visits, both English and Spanish are used when I'm the provider. I always make sure that the family member who's there, who's only Spanish speaking, gets to hear from me what my impressions are, what my questions are, and what the plan will be. And so that's a critical thing in having everybody on board. Next slide. Okay, this is just a very quick global eye view of some of the social determinants of health by category. I'll tell you a little bit more about his social history. He basically immigrated to the US from Mexico at the age of 7 with his parents. And as I said, his parents do not speak English. He completed high school. Right after high school, he was not able to go to community college. Reason why was that he had to work to help support his family. And so he did that for a while in his 20s. He basically has lived with his parents for well over 10 years now, especially since he had to stop working in a factory. This was almost 10 years ago due to worsening balance and falls. And so he lives with his parents. He doesn't like to go out. His mom says that he can spend up to 3 weeks at home without stepping outside other than to go to the garage and then back in. So he lives a very isolated lifestyle in that sense. And so that also highlights the challenge that going to PT at Rancho Los Amigos has also presented for him, which is related to the fact that he does not like to step out of his home environment. And so basically general topics that these issues bring up are vast. So, immigration, acculturation are two very important ones. What it's like to grow up bilingual in a city like LA, and the challenges involved in that, especially when the patient has to seek care. And so that's an important thing to keep in mind. The parents, in this case, were late immigrants. So they were likely to have poor acculturation in the US and maybe not understand the way the medical system performs. It's a strange beast, if you can call it that, and especially so we're dealing with the limited resources of the LA County Hospital as well. There are linguistic barriers. There's a limited educational background as well to consider. And then the health literacy is also limited, as you can see from one of the beliefs of the patient, for example, about vitamin D and what it can do from his perspective. And the same thing goes for, in the case of Ampera, in which he thought it was one of the DMTs for MS, but somehow that had not been very clearly conveyed to him. And so, as I said, all of these things can be discussed at length. I know we're short on time, but I believe there might be one more slide. It might be the last one. That's right. These are very general questions. Basically, the cultural relevance to MS as the diagnosis and treatment. And so what does it mean to be culturally competent? And one of the big questions, does the patient really understand the disease? To what extent? Are they comfortable with the diagnosis of MS as well? And then our roles as providers to be able to understand the social cultural context from which they are coming. And then the tools that we can have at our disposal in order to help them reach the right decision in the case of the treatment plan. And this has been one of the biggest hurdles and challenges with this particular patient that I've encountered this year. And so these are things for us to think about. I believe that's it. I open it up to questions.
Thank you very much. And thank you to all of our speakers. Thank you for all of our attendees for hanging in there. This we did go over a little bit, but my goodness, this was such terrific information from each speaker, very relevant to each of us and for all of you for your practices. Are there any questions from anyone?
So there was nothing in the chat box, but I am looking at it. So if anyone either just wants to speak up or put something in the chat box. Nina wants you guys to know that everyone did an outstanding job. Thank you, Nina. Any other questions or thoughts that anyone wants to share? All right, Kathy or Sarah, you want to close us out?
Sarah,
Yeah, so I think, sorry, Kathy, did you have more to say?
no, I don't. I was just saying, go ahead.
So thank you everyone, to our amazing speakers and everyone who joined us tonight. This was really such a great opportunity to filter out this information. We appreciate all of you. I know there's a zillion other extra priorities all on our plate right now, so we appreciate the time that you dedicated to this. We did record this session, so we will be pushing that out to you if you want to take another listen, or if you want to share it with your colleagues. Keep your eyes peeled on your email for that. And if you have any other burning questions that come up later, we would be more than happy to filter those out to our distinguished speakers. So other than that, everyone have an outstanding rest of your evening.
Thanks very much.
Thank you, everyone.